Good afternoon. My name is Nasser, the program manager of the program, Kebbi. So on this line of this, John and with me on the malaria program. So can we go to the background description? So for the description of the program is the malaria program is destined to prevent malaria infection among the under 5 children during peak season, that's what we call SMC, and also to reduce malaria-related illness, severe disease, and also death to the children. Also maintain protection level and malaria drugs throughout the peak period. And also describe malaria-related at hospital admission, interventions such as insecticide treatment, diagnosis at the facility, and also effective treatment. For key objectives of the malaria program. I'm not seeing well. Consistent in another. Ajuya. So our key objective is to prevent malaria in children and also in the public. Also to reduce malaria cases by 80% in the population. So where this aligns with the AOP and national priorities, one, reducing malaria morbidity and mortality among the children under 5, increase the number of malaria prevention intervention in higher community, strengthening the health care and community-based service delivery through integrated outreach, and also improving child survival and continue to achieve state malaria control target in line with the national strategic plan. This slide. So this is performance from the SMC administration, one of the key interventions of the malaria. For this year, cycle 1, that's when we targeted 1,431,933. And we were able to achieve 1,342,328. That's children that we were able to reach. Based on the target, we achieved 93.7%. We have by 889,685. Next slide, please. So this is the after administration of this pack, we want to see actually what is happening, and this is what the result that we get in survey. 92.8% is the coverage based on the NPS, and for those that get full cost of this pack is 96%. Then those that get direct that is 94.7%. This is this is for the item distribution that are done this year, and we targeted for 3,145,650, and what we achieved is 3,120,770. So can you go to the slide so that we can see the basic percentage? So our target is for us to get nearly reduction 100%, but so far we are able to get 98%, and the value is only 2%. Next slide, please. So this is one of achievement. SMC implementation SMC, and each year we successfully meet. Then over 1 million is supposed to be each annually. Then we also have civil coordination across the target community. So regularly we used to reach the target. Then we use the SMC platform to integrate malaria vaccine that introduced in 2024, which Kebbi is the state that the program was planned of. So we integrated, we start piloting with 3AJ, and in cycle 1 in the main cycle we were able to reach 20 AJ except Zakaba. Then highly implementation of an official come out to the mass administration of the net. So we're able to see a high percentage of people that come to receive their net administration. So what partners contribution of technical support to workers, and also this based on the campaign that are doing economic contribution to movement that enhance livelihood of many people. Then we also partners with 557 facility which malaria communities, which is by monthly distributed. So we have some new innovation that improve in the implementation. Malaria will be the first program that in campaign, and also have electric dashboard for real-time monitoring of campaign program. We have a decision during each review meeting by seeing what is happening in each community or settlement. Then integrate services linking with SMC and other interventions, such as malaria vaccine, and also this time around we add work and zinc in Albon, piloting in Albongo for first cycle. Then in this coming cycle we are planning to reach more the energy in the state. Next slide. Okay. This is the under 5 permanent from 2015. When I'm in office, 2015 we are at 63% of our reduction of malaria at the highest burden of malaria. But it was recent survey in 2025, Kebbi with 18% of under 5 pregnant. At least we need to attribute malaria from 63% to 18%. Which is more than 100% reduction. So next slide, please. So this is some key challenges that we have. Children is an area that faces that is hard to reach. We have to go of reaching those people, and also sometimes the insecurity. Then sometimes getting timely reports to track is that we are still working with it. Then managing logistic challenges, especially in terms of reverse logistics of reverse commodities that have been the meaning of that campaign. So this is some of the challenges that we have. Then in data and reporting issue, we have delay in synchronizing and also reporting during the implementation, incomplete and inconsistent data, which affecting the quality and report days of optimal submission in process. by most of the NGT. Additionally, from usually some people are not sharing it. So this slide, please. This slide. Okay, in issue of data quality completeness for recent data that we see, we have 99% and timely reporting is 98%. For accuracy, decade.com is 65%. So for equity and inclusion, we look at it and we don't have justice for it. That's why we say it's 50-50. Malaria intervention is for everybody. That's why we cannot have some for female or for men. Next slide. So this is financial analysis. So far we have for the state. We're not able to get for partners. So for 2026, this is the budget, and we do some approval, but up to now there is no release. So we have 100% funding now. Next slide. So this is one of recommendation. Steady essence macro plan training and also community mobilization, improve data collection and reporting and real-time monitoring of the campaign performance. That's a short-time recommendation. Then for mid-time setting supervision, data quality assurance and capacity building of health workers, improving integration, assembly and other child health intervention, like vaccine and other intervention. Then for a long time, we need to continue monitoring and motivating, taking award for those that are performing very well. So next slide. So this is supposed to prioritize in this coming annual operational plan by the grace of God. Next slide. And this is the conclusion. Essentially, is effective malaria prevention strategy that protects under 5 during the peak season, and also has improved access of prevention and reduction of malaria, and even the severe bleeding. Based on the report that we are seeing, Kebbi will have most issue of severe malaria, and also strong coordination, quality data, community engagement, and sustainable financing across critical for continuous success. So this is the goal for the action, setting ownership, government on and driving organization, because mostly it's driving, ensure availability of medicine support for licensed workers, engagement to achieve higher this is our coordination. This is the last.
Yes, thank you very much for the presentation. We have 88 HIV/AIDS. We're going to take 4 for this category without HIV/AIDS, please. After this, the TB. That is forward. After NCD. NCD. Okay, yes. It should carry. So now.
I'm going to SASCAP and representing SASCAP and this is the first one. This is the overall and 26 states and facilities. The program expand HIV AIT means PPC service to prepare to change the distribution. Prior to the state annual national plan, for control and at the global unit in 5.5 targets. Receiving PMTCT service. The target 2026 record as 95% for all indicators. For all indicators. Achievement is 370 tested, 99, 22,994 on treatment and 18,617 are wireless supplies, while 6,468 coverage is 33%. Next slide. These are the key indicators. The HIV test achievement 370 against 148,459 baseline. 2026 target recorded as 0.99%. Then for the ART enrollment, achievement is 22,994 against 14,668 baseline. 2026 target recorded as 0.95. Then for the PMTCT coverage, achievement is 6,468 against 3,802 baseline. 2026 target recorded as 0.9%. Next question. These are key achievements. 18,617 clients achieved wireless operation against 13,917 baseline. The HIV test achievement is recorded as 370 against 147,459 baseline. Then for the ART register shows 22,994 HIV active on treatment. Then for the PMTCT coverage is 30%. Enders and DHIs and NHMS dashboard now use tests ART and viral load reporting across all reporting engines. One of the achievements is the facility level ART and PMTCT and monthly summary register coordinate across the state SESCAP coordinator, LGA, NACA, and OGA teams to sustain the reporting. Next slide, please. Is our key achievement. ART enrollment is 22,994. Then for the binary suppression out of 22,994 clients, 18,617 were binary suppressed. Then for the PMTCT 460,000. Next, these are challenges and ARV commodity supply. The prevalence for home delivery and inadequate staffing limited PMTCT coverage. Poor adherence to the test and treat. Incomplete ART reporting, inadequate reporting tools and referral grace. Human resources is also one of our challenges. resource gap. In some areas, and community engagement contributed to continuous signal lack of budget and means for HIV/AIDS intervention. Next slide, please. For the data quality assessment timeliness, the data updated as at June 2026 for accuracy sourced from NDAS, DHIS, NHIS dashboard and facility ART, PMTCT and monthly summary register. The reported ART enrollment achievement for 14,968 PL HIV on ART and 13,917 were virally suppressed, while 3,802 pregnant women received PMTCT. Next slide. For equity and inclusion, gender disaggregated. Source register are disaggregated by sex where applicable, two not broken out in this summary. LGA disparities, data aggregated from all reported LGAs and facility. The LGA level breakdown is available in source register. Next. And for the resource and finance analysis, budget allocation, no release of funds budgeted for community availability, that is HIV test kits and ARV drugs. Intervention are fully donor dependent. Funding gap, recurrent ART case, test kit, and ARV stock out are reported as key bottleneck across the testing, ART, and PMTCT service. Recommendation for the short term, ensure uninterrupted HIV test kit and ARV supply, strengthening supportive supervision and data quality assurance review. For the medium term, improve ARV commodity distributed and provide adherence to treatment guidelines, increase facility delivery and staffing for PMTCT. Then for the long term, enhance community engagement and strengthening action against stigma, reduce referral delays and improve access in security areas. Priority action for 2027 AOP. Secure uninterrupted ART and ARV commodity supply. Improve the PMTCT coverage. Responsible actors, state SASCAP coordinator, PM SACA, health facility, LGA, LACA, and MIE teams. Timelines aligned to the 2027 State Annual Operational Plan cycle. In conclusion, the Q1 2026 review indicates that Kebbi State has made a notable progress in HIV program implementation, particularly in expanding antiviral therapy ART enrollment, increased barrier load suppression, and improved PMTCT service uptake beyond 2021 to 2025 baseline. The adoption of NDAS DHA program monitoring and data management across reporting LGS. However, persistent challenges include inadequate HIV test kit and ARV commodity supply, human resource gap, limited domestic financing, weak adherence to test and reporting protocols, continuing dependent on the donor funding, continue to affect the program performance. Going forward, priority should be placed on ensuring financing for HIV intervention, improve data quality and reporting, and enhance community engagement to accelerate progress toward achieving the 95-95 target and inform 2027 Annual Operational Plan, AOP. Thank you.
Thank you very much for your presentation. presentation. Next presentation, TV. Yes, I want the TV.
Okay, good afternoon. Let me stay on the present protocol. I'm from Pakistan. I'm here to present the TV program activity for the quarter 1 2024. Next slide. Okay, this presentation is only to TV. You know, we are working with the leprosy through the ulcer. So this presentation is limited only for the TB. So the tuberculosis control program is a public health intervention aimed at reducing the burden of TB in the state and the country through early detection, effective treatment, prevention, and community engagement. The program followed the WHO NTB strategies and the National TB Leprosy and Bullying Program NTB LCP guidelines. It provides diagnosis, treatment services at designated TB treatment centers. Both sites and through community outreach. Key components include case finding, laboratory services, drug supplies. This slide. This one is second slide. The first one, previous one. So the key components include case finding, laboratory services, drugs management, TB HIV collaboration, contact tracing, infection control, and TB data management. The program also addresses the drug-resistant TB, child TB, and TB in vulnerable population, and TB treatment. Next slide. The key objective. The objective is at least 80% of estimated TB cases in the state through active and passive case findings, achieve 29% treatment success rate for all forms of TB through both and patient support. Scale of infection prevention and the control measure in the health facility and the community. Ensure 100% TB HIV for TB patient and provide IPT and ART where indicated. Early diagnosis and enrollment of DRTB cases on appropriate treatment regimen, increase awareness, case demand and the involved community and the CSO in TB response. Strengthening data and surveillance, ensure timely reporting and the use of TB data for decision making. Next slide. Allow me with the state AOP and the national program. We have 3 areas alignment with the state AOP and alignment with the national program of TB and national TB and response program. The goals contribute to the state AOP objective of reducing communicable disease burden and the probable population health. To the national with the national strategies plan to end TB 2025-2030, reduce TB incidence by 50% and the death by 50% by 2030. Service delivery, expand birth center to PSC per state, AOP and primary health care strengthening. Implement national TV and literacy control program service delivery model, facility-based, community TV care and case finding. Case finding, steady OP priority, scale of active case finding in higher burden local governments. Support national target of finding 70% of missing TV cases through ACF screening and contact investigation. Commodities, quantification and supply chain system for TB drugs and gene export cartridges. TB HIV, allow to state AOPH, TB HIV, 8 pillar for integrated services, implementation national TB and HIV collaboration program. TB program performance for the 2024-2022. This is our performance for the first quarter 2026. The baseline is 22,336. Our target for 2026 is 25,000. We achieved 4,989 in the first quarter. Treatment success among the patients, we are up 20. Our target is 21,491 in 2026. 831 26 facility with TB diagnosis access diagnosis access. We have the target of 21. 2026 we get 28, which will have across the state. Eligible contact trace screening 14,338. Our target for this year is 16,925. We contact trace 4,981. Consistent TB case management. We have the baseline 1. Our target for this year is 120. In the first quarter, 2020, we get 24 patients. Next quarter. Quarter 2020. Activity was successfully achieved. Advocacy for the team of the RTB patient as vulnerable group, advocacy to malaria for preparation for SMC, TBX outreach we are planning based on TB home TB alert, TB endemic, TB endemic. Next slide. Our challenges and bottlenecks. Commodities and supply chains. Stock out of RNZT, RNDPT due to delay procurement and poor forecasting. In export cartridges, insufficient cartridge and frequent downtime of machines. Case finding and service delivery. Cases diagnosed, treated in PM site, not reported. TB under diagnosis, weak capacity, and low index of suspicion. Human resources. Train staff transfer of our replacement, capacity building, and regular training of evangelists and tools. Financing. Heavy dependence on the donor and partners. Delay plan release by step counterpoint release date, affecting the implementation. Next slide. So data quality. In the data quality, in the complete link, we have the target of 100%. In 2020. 5, we have 88%. In 2026, we want to achieve 25% for improvement. Timeline, the timeline of the quad data in 2025 we have 75%. In 2026, 86%. Need to push. Accuracy, the accuracy of data we have the target of 100%. In 2024 we achieve 95%. In 2026. 96% close to the target. Validation status. We want to achieve the target 100%. In 2026, we have 80%. In 2026, we have 80%. Next slide. So, resource and financial analysis in TB in 2026, we have the budget of 185 million. And 125. In this quarter, we get the approval of 90 million. We receive 20 million. Now we are working for the release of 70 million. Next slide. Recommendation for state TV program 2026 to 2030. Conduct target ACF voting local on using mobile TV lamp, roulette machine, and community volunteer. Totally supporting supervision to all those active WhatsApp the voting group Tamboy. Conduct emergency notification and group stock of TV books, TPT and then export cartridge for prevent stock out. Medium term. Upgrade 30 additional PSC to post center, train health worker on childhood TV and IPT, ensure 100% testing for TB patient and screening for all people living with HIV/AIDS in the health clinic long term. Increase state regional allocation for TB by 50%. Establish state TB transfer to reduce donor dependency. Equip all general hospitals within expert and X-ray, establish the activity between center and TV zone. Next slide. Priority for 2027 AOP, key focus area for 2027, TV case filing through ACF, content investigation, and PPM. Universal access to quality and strong data and government ACF community under and Kebbi business program. Next slide. Conclusion of action. The state TV program recording and promoting the case notification, data completeness and the in 2026, driven by the partners for and target ACF. Teacher legend passes, shortage of TB duty, so we need to strengthen priority. Duty is strengthen the voting, validation and use of NHIs for real-time decision making, resource analysis should help people know dependency with critical gaps to prevent transmission and sustain the response and sustain the response to domestic violence. Subject application, integrate TV services to basic healthcare fund and state health insurance. To LG and facility managers, 100% reflecting commodity accountability and the active supervision on the TV response act. To all stakeholders, let's work together to end TV by 2020. No TV patient should be left behind. Every case counts. Every life matters. Round TV, Prime TV, Click TV. Together we can achieve a TV state. Next slide. Thank you. Thank you very much.
We are taking the last one, then we now listen to. No, John is not ready. We are taking ACD, please. Then we now take observation. Okay.
Hello.
Assalamu alaikum. Is Malami Mohammed Ibn ICD unit as a non-communicable disease. Next. Program overview. Overall performance across major indicators remains off track due to severe shortage of machineries and special NCD drugs. 2. Primary objective, expand access to screening, management, and early detection of non-communicable disease, that is hypertension and diabetes in brackets, across primary health care facilities in the Kebbi states. Alignment with state AOP and national priorities fully align with the sector-wide approach, that is SWAT, and the 2026 Kebbi State Annual Operation Plan AOP, targeting essential health packaging expansion. Scope intervention, facility-based screening, functional NCD clinics, community outreach, tracking for core NCD. Next slide. Program performance summary. Baseline 2025. Hypertension screening 2798. NCD clinic functional is 360. Community in 18,450. Target 2026. Hypertension screening is 11,63,000. Also, achievement. Hypertension screening is 8,500. Diabetes screening 2,999. NCD clinic functionality is 141. Community screening 4,550. But also parents. Hypertension screening minus 2,690. Diabetes screening is minus 2,349. NCD functionality is minus 800. Community screening is minus 18,450. Next slide. Key indicators. Target for hypertension screening is 11,190, while the achievement for hypertension screening is 48, while achievement is 2,999. Indicator 3. Target for NCD clinic functionality is 941, while achievement is 140. Next. Okay. Key achievements. Major achievements during the review period include expanded hypertension screening to primary health care. 2. Expanded diabetes screening to primary health care also. Expanded facility offering basic NCD services. Expanded availability of co-NCD medicines. Expanded community-based NCD contribution World Health Organization. Okay, data quality assessments. Data quality assessment, we have hypertension screening is validated. Then diabetes screening is validated. NCD clinic is validated. NCD drug ability is pending. Then community screening is pending. So the source is primary data source, including HIS2, NHMS, monthly summaries, facility assessment report, and outreach meeting reports. Equity.
Yeah, okay.
Equity and inclusion, geography parities, that is concentration of screening numbers, primary in Kebbi and urban. Equity facility in hand to reach local government. And we have gender discrimination, that will return gender discrimination in require across all the HIS reporting to track male and female screening rates accurately. PLWD inclusion, target outreach, campaign to actively involve persons living with diabetes, PLWD, and regularly framework to ensure subsidized care. Next slide. Resource and financing analysis, budget allocation, expenditure status, funding gaps. Okay, recommendations. Plan action. Procure and distribute additional screening equipment. Team action. Conduct statewide sensitization and community screening awareness campaign. 3. Long-term priority. Establish timely screening protocols, school health facility coverage, and sustainable drug logistics. Priority action for 2027 AOP. Additional partners on board new development and technical partners to bring supply chain gaps. 2. Financial support, required response for machineries procurement. Health education, sales of public health education of basic STD screening for all primary health care, that is higher priority in bracket. Supply chains, strengthening. Integrated essential NCD drugs into the regular state LMIS procurement system. Local government expand community outreach and functional NCD clinic beyond Kebbi and urban. Responsible actors. Ministry of Health under state NCD unit. Kebbi Primary Health, CHCDA, WHO, and development partners. Priority ranks, higher priority, that is evidence source, DHIS2, and supervision report. Conclusion, summary. Inadequate supply of drugs for NCD and from government and partners. 3. Health education. Thank you.
Thank you so much for your wonderful presentation. Okay. While making presentation, we have the privilege and opportunity of having our royal fathers here present, representing Emir of Argungu. Sir, you are welcome. Malaria, TB, HIV/AIDS, and NCD. Do you have any observation, any reaction before we move to the next presentations, please? Thank you. Any other one? That's two. That's number 3.
Thank you very much, all the presenters for the presentation. But
wanga abun wane ne?
cikin haɗu ina da saman wurin na mutane.
You mentioned PMTC over the system. You mentioned PMTC over the how do we achieve therefore, keep preparation